Shinpaugh, and I work at the Virginia Bioinformatics Institute, which is one of the large institutes at Virginia Tech. Just kind of a mission statement for VBI. What we're trying to do is use informatics, so we're trying to model everything from, single cells, biomes, et cetera, might be in somebody's gut, all the way up to worldwide human populations and the interaction of people with technology, viruses, and et cetera. So we can basically help improve human health, et cetera. Here's the computational resources VBI has. It's not large by the supercomputing standards, but it does perform. One of the key things, it is a resource that we have ourselves, and that means that we can schedule things when we need to. We're always computing. We have a continuous compute demand, and we're always delivering services out to our contractors and other agencies. So basically we have, and as somebody mentioned this morning, it's a hybrid cluster in a sense. We have large memory machines, we have large nodes, we have nodes with different configurations of memory and various processors as well. And we are using GPFS for the file system. So now I'm going to talk about some of the work we've been doing for essentially for the past 9 months, and that's doing the modeling for the Ebola outbreak in Western Africa. And so the way we have to do this is we build a synthetic human population. So we start off with census data. So from the census data, we'll generate all the statistics for that population, and then we'll generate a synthetic population that has some of the same statistical information about that population. But there's not a one-to-one mapping. So if you have Bob Smith here, there is no equivalent of Bob Smith inside the synthetic population. So there is no privacy concerns. To do this sort of modeling, and also somebody mentioned that MPI is not used often in bioinformatics. Well, actually, this is a very large-scale MPI-based code sets that we have here. And I'll show you later how well that's run on large-scale machines. So once we have the synthetic population, we then have to actually generate the information about where these people are. So we have the road infrastructure, the buildings, we have information about where they work, how they interact. So you have people that might go in the morning, they go out to the coffee shop, do something, then they go to work, they do something there. And each time these are interactions that can happen with people. And it's those interactions that can allow us to look at how a virus might spread through that population. But we can also do beyond just that. We can also look at, okay, if a disaster happens, what happens to the cell phone network infrastructure? What happens to the road networks? What happens to the power system, et cetera? So we can do just about any level of simulation. And a while back, we did a simulation where we exploded a 10 kiloton bomb in Washington, D.C., and then looked at what the people did. And one of the things we found is that if you can't bring up like the cell phone network very rapidly, people are going to make bad decisions. Because if you have your wife's working here, you're here, and your kid's over in a daycare, what does everybody want to do? They want to go help get the kid. Well, if the cell phone networks are not working, they're not going to have the information they need, and they'll make bad decisions. So with these tools, we can look at a wide variety of things. So here's kind of how the infrastructure maps out. So we get the census data from all the countries. Right now, we've been doing the U.S. now, about 300 million people in the U.S. And then we had to get the data for the Western African countries. And that was kind of hard to do because there's a lot of times not very good data there. So what's different about some of this stuff? We actually have several programs that we develop. Epidemics is the big one. It does a lot of high detailed information. You get location information about the people who have maybe swine flu or bird flu or Ebola. And then we can also look at how that location moves over time. The other ones are much faster running programs. Also, we have portals that provide this information to various researchers around the world to also use, and also policymakers themselves. To give you an idea of how well this scales, we ran on Blue Waters at 352,000 cores, pretty much linear scaling. So we can do the entire United States population in 12 seconds. And that's one simulation run. We need about 100 of those runs to get the statistical data that we need. We project that we can do the entire world population in about 6 minutes. And we're hoping to get the data for the world. We're in the process of collecting that data now, so we're trying to get all the census data, all the road network data, et cetera, so we can start doing global epidemics. So back in June of last year, when the Ebola crisis was starting in Africa, the Defense Department, through the Defense Threat Reduction Agency, who is our prime sponsor, reached out to the various groups and determined who has the capability to do modeling for Ebola. So in June, we started that work. And so initially, we had to do some just initial, very basic simulations. And earlier, we showed that maybe about 1.2 million people would be infected in Africa by December-January timeframe. You may think, why is there a big difference in the number of cases? And you got to realize that this is based on nothing changing. So if nobody takes any action, no hospitals deployed, everybody does their interactions as normal, you would have seen that big increase. So here's some data from October. This is when we really started getting more detailed simulations. And so one of the key things we had to do, most of our models are based on sort of flu-like epidemics. So that's spread through atmospheric and other contact like that. Ebola is different. With the flu, you're contagious before you actually know you're sick. With that Ebola, you're pretty much, once you're sick, you're contagious, and then you're contagious even after you're dead. And that was one of the big changes that you see from like other flus and et cetera. So originally, the data coming out of Western Africa, about 13,000 cases at that point in October, and about 5,200 deaths. So some of the key questions they were asking us was, can it make it to the United States? And our conclusion was that if it did make it into the United States, it would not spread very rapidly because of the quality of health care. And also the quarantine methods that we can take advantage of. Here's some of the forecasts we did in October. So you see over time, we're giving the DITRA updates every week on the progress of and what our projections were going to be for the coming future. Here's kind of the current situation. So right now there's about 25,000 total cases, 14,000 or 15,000 laboratory confirmed cases, and so far about 10,000 deaths. Here's kind of how you can see in November, we get a change in the number of cases. And that's what we think happened is some of the medical equipment started making to the Western African countries, especially the protective gear. People started changing their behaviors. So one of the things they stopped doing was, the burials there are very hands-on, and so they did change that mentality so there wasn't as much physical interactions with bodies at that point. Also, the field hospital units were also coming into play as well. So through simulation, we showed that if nothing was done, it could be a very dire situation. And luckily, the world responded very rapidly. So here's kind of some of the information they asked was how bad was this going to get? So our initial projections were about 1.2 million deaths in those countries. What would happen if it came to the US, which basically we concluded that it would not be a serious threat. Some of the work that we're doing now is, what if we had vaccines available in the June or July time frame? How much difference would that make? And then also, where should they direct resources to help respond to the situation? So initially, when we were developing models, we were looking at some of the data as it occurred in real time to try to get our models to match what was going on the ground. So in October, the Defense Department came to us and asked us, this was actually on a Friday afternoon, they said, where should we place the field treatment units? We need to know the answer by Monday morning because Monday afternoon the planes are taking off for Western Africa. So we did some modeling on that. So basically what we looked at was, what was the virus going to spread? What was the road networks like? So earlier this morning somebody mentioned that this region of the world was just coming out of the raining season, so the roads were pretty impassable at that point. So that means that, hey, one of the advantages, people can move around, but that's also a disadvantage because people can move around and spread the disease. Some of the other things that came into play here is politics. Essentially, there's governors in each one of these regions, and so you had to at least place one field unit in each of the governor's sort of counties or whatever you want to call them, or states. Some places, some units have already been placed, and then, so basically the green crosses represented where the optimal location was for our, based on our analysis. Now, getting some of this data was difficult. We wanted to look at how regional travel was going to affect things as people came out of the rainy season. So we actually found a company that had cell phone data records from the year before. So we can analyze that cell phone data and look at how people moved around the roads and also how people moved by air travel. And that helped us predict what it would be like this coming year once the rainy season finished up. So for the most part, we're providing operational support to the Defense Department. So we're providing weekly updates on our projections. They'd also ask us critical questions like, where should we place these field units? What sort of, so if we deployed certain measures, like protective gear could make a very big difference in the spread of the virus. We also were looking at how to improve our models. So originally I mentioned that our models were based on flu-like a virus, so that spreads by aerosol. With Ebola, there is a really physical contact. Also, we're trying to integrate new data sources. In fact, we just released to Africa a application called Eyes on the Ground. So it allows people in those regions to give us information about the road conditions and other things that they can report to us, and that gets back to us. Then we can look at how that information might be used in our models. We're also looking at how to design and plan for future outbreaks. So not only this, but in the past we've done bird flu, H1N1, H5N1, or something like that. And then also we're looking at hypothetical scenarios involving vaccines. So suppose we had 10,000 vials of vaccine in September, what difference would that make? How would you distribute that across the population? So this is basically an agent-based modeling. And so one of the key benefits is that we're looking at kind of the human behavior, human interactions, so really trying to figure out how these things move around the populations. Here's the virus data I mentioned. So this is 10,000 vials or doses, and so here we had various campaigns and looking at the effectiveness of these campaigns in preventing the virus spread. So you can see in some cases you can get up to almost a 50% reduction in the number of cases. And this is with various how effective the doses might be. Pardon me. So pretty much it seems like Ebola's it's really on its way down. I think there's recently a news story where a few new cases have shown up, but in the most part it looks like it is being contained. Sierra Leone Liberia had a very good progress, and now we're seeing progress in the other countries. The U.S. had The U.S. was responsible for one of those countries, and then I think England and France were responsible for another country, and et cetera. So this work here is done by about 75 people at VBI. They're in the Network Science Dynamics Simulation Laboratory. And when we were in this operational mode, providing data at DITRA, it was very hard for us to do research. Now we're coming back, now that they've pulled out of the country. Now we're more looking at what can we do to improve these models, what information sources can we increase, and we're in the process of also generating the worldwide data as well, which will probably take us a few years. So here's some of the people that have been involved in this work. And we've had a webpage with our weekly updates. So you can go to this website to look at the weekly updates on Ebola. Sorry about that. If not, I'll take some questions.